airways, because it's a patchy process with VOS, that show us the obliterative bronchiolitis, what secondary histologic features can we see? There are a bunch of people wearing t-shirts, you know there was a party last night, but you weren't there. Similarly, in the lung, are there features that we can see that show us that chronic rejection is there? So this would be accumulation of foamy macrophages, cholesterol cleft-laden macrophages, features of obstruction, so that we know that the airways have been obliterated. And then she also encouraged that the transbronchial biopsy and the BAL were great tools for further studies and molecular studies. Then Jan van der Thusen took us through explant pathology. What can we learn from our explants? These provide a large amount of tissue. And for the native lungs, when they come out, is what we see in the native lung, does it correspond to what we saw in the VAT switch biopsy? And are these two, are we doing a good job on our biopsies? And are those correlating with what comes out? And then the other big piece of this is, are there additional findings in those lungs that may impact the patient's course post-transplant? And these would be malignancy. So in about 2% of our lungs in a few studies, carcinoma has been identified. A lot of these patients are transplanted for emphysema, and then also infection. Is there TB, is there aspergillosis, et cetera. Looking to the allografts, when someone has a reedy transplant, is there recurrence of disease? What are the features of chronic rejection, and can we learn more about chronic rejection using these? And then what else are we seeing? Are we seeing drug toxicity? Are there infections there? And are we seeing malignancy post-transplant? So in a nice study out of his institution, in which he was the lead author, looking at restrictive allograft syndrome, or RAS, showed that yes, the typical features of fibrosis, organizing pneumonia, NSAID-like fibrosis are there, but also AFOC was there. And you can see, he showed nicely that there is increased evidence that AFOC was organized into what we call RAS, and no DAD was seen in this study. Some additional sort of associated features which he highlighted were the loss of alveolar septal capillaries, which you can see here highlighted by the CD31 stain, some ectasia of the lymphatics within the lung, also highlighted by the D240. And those are some things that had not been particularly called out previously. So explants are a valid source of tissue and should be reviewed for unexpected findings and used to form hypotheses about what's going on in the lung. So moving into the next part of our talks, which sort of looked at newer technologies. We all have heard a lot about nanostring technology, and Dr. Ben Adam out of the University of Alberta took us on a really nice tour of some of his work, and he sort of took his orders from the last Banff report, or at least it appears that he did. And so in the prior report, what we said was that we need to look at the lung and look at gene expression analysis and see if we can figure out exactly what is going on in the setting of AMR, because we are really limited in the lung by some histologic features which can be nonspecific, and the C4D stain, which, to be honest, is really not always helpful. So using the nanostring technology on formalin-fixed paraffin-emitted tissue, there was a pilot study looking at lung, and can we use genes that have been previously reported in the literature in lung transplant? And if yes, hopefully that will lay the groundwork for a multi-center study looking at pulmonary AMR. And so the gene sets, as I mentioned, that were used in this particular pilot were those that had been reported in the literature for acute cellular rejection, acute lung injury, antibody-mediated rejection, and then just to make sure that we're staying honest, some lung-specific proteins and housekeeping genes. And so I think during the first part of this literature-derived gene set, while there was some differential expression, was very limited in its specificity for AMR, acute cellular rejection, and acute lung injury in the lung. showing that while we do look to the kidney and the heart, things that are happening in the lung appear to be a little bit different. And so there was this novel 10 gene set for acute cellular rejection, an 11 gene set for AMR, and a 5 gene set for infection that came out of this. And sort of to summarize, firstly, yes, there's great tissue in the transbronchial biopsy that can be used for nanostring and molecular studies. Using gene sets from other organs were suboptimal, and now that we know a little bit more about where to go in the lung in terms of what the genes of interest are, hopefully we can follow this up with a multi-center study. We'll come back to this on the last slide. So Jamie Todd out of Duke followed this, and instead of looking at sort of an AMR focus, her her orders came from a document that the ISHLT put out, and this was after a consensus on CLAD. And so she was using nanostring and CLAD and saying, okay, here are the two phenotypes. We have BOS on one side, we have RAS on the other. What is going on in the tissue? And so what was done in this study is look at the features of RAS and BOS and take a small number of each of those, perform laser capture microdissection, and then see where we are. And so for the normal comparisons, for BOS, an uninvolved airway from the same patient was used. For RAS, normal alveoli from the same patient, and then donor trimmings were used for this study. I think one of the things that Jamie highlighted throughout her talk was that there were many lessons learned during this whole process, and I worked with her on this, and it was exciting and frustrating at the same time. But we do have some early data back. This is using the NanoString pan-cancer immune panel. The hot panel was not out yet. And on the far left, you have normal airway. In the center, you have a patient with BO, and this is an unaffected airway. And on the far right, you have an airway affected by obliterative bronchiolitis. And so we are seeing different gene expressions, thankfully. And this one, this is looking at RAS on the far right. This is the pan-cancer immune panel. You have normal alveoli. The center is from a patient with RAS, but looking at normal alveoli. And then the far right, you have an area with RAS that was dissected out. So again, some differences being seen here. And then lastly, this was the pan-cancer progression panel. Again, a patient with BOS with normal donor trimmings on the far left, the center being an unaffected airway from the patient with BOS, and the far right being from the same patients with an airway lesion affected by BOS. So more on this pilot study. And so I think her take-home message was that for nanostring, yes, the tissue is usable. We did a number of pilot studies here, and in the end, no, we did not need to do any more pilots. Yes, the tissue was usable for nanostring. It was very helpful when we cut the slides in RNase-free conditions and kept them at -80. And then it was yet to be determined how old is too old for tissue. Lori Snyder spoke a little bit about CMV and the immune system. Her hopes were that we could figure out specific signatures of T-cell immunity in patients that would predict risk for infection, and then we could tailor prophylaxis. She highlighted a new study out of Sydney where CMV immune monitoring was used to allow for an individualized approach to CMV prophylaxis, and then went on to highlight a study she's involved in that's looking at the protective signature against CMV in hopes that we can use this moving forward. So looking at using a T-cell assay to look at a patient at the time of transplant or after increased immunosuppression based on their serologic status following treatment, perform the T-cell assay, and either stop prophylaxis at that time or determined if secondary prophylaxis is needed. So hopefully some exciting work going forward there. We heard from Adriana, who is always a captivating speaker. She encouraged us, as always, to consider, when looking at DSAs, what is the risk, because not all DSAs are equal, and that we can't just look at the strength of a DSA, that you need to look at it in the context of what is the titer, can it activate complement, if there's a high MFI, if the MFI is low, what is that IgG subtype in terms of treatment evaluation and monitoring response. So not all DSAs are created equal, and we really appreciated her reminding us of that. So moving forward, looking at the graft itself, Jean-Luc Taupin out of Paris talked to us about, can we look to the graft to see if there are DSAs there that we are not seeing in the serum? And this has been done previously for over 40 years. The technique has changed, but there's still only a handful of manuscripts in the literature looking at in situ DSA. So the question here is, what is the predictive value of an intragraft DSA in the setting of lung transplant? So he has a study that is currently in press looking at intragraft DSAs and the phenotypes of CLAD, so RAS and BOS. And sort of the two take-home messages here were that a serum DSA and the graft DSA were important in both RAS, and more so in RAS than in BOS. And that there were cases, especially for RAS, where you were serum DSA negative, but graft DSA positive. Moving forward to non-HLA DSA, so Jessica Dragon out of Berlin took us on a tour of the angiotensin 1 receptor antibodies that she has worked with, as well as the endothelin receptor antibodies, and showed us that in other organ systems, again looking to the kidney, that some patients were able to be reclassified as having AMR when there were not any other, there was no serologic evidence otherwise of that. And so her take-home messages were to us that the anti-angiotensin 1 receptor and endothelin receptor antibodies are of interest, that there is evidence for some crosstalk between those and class 2 HLA antigens, that these two non-HLA antibodies are able to damage the allograft and provoke an inflammatory response, and that if you see them in the pre-transplant setting, that there are definite therapeutic implications. So lastly, we heard from two clinical colleagues, Debbie Levine out of Texas, and looking at this sort of 5-tiered approach to AMR in the lung, which is sort of was put forth in 2016, and it's kind of what we're clinging to right now. It definitely has limitations. So the C4D we know is not great in the lung. There are issues with antibody detection. The pathology, while we like to think it is very robust, it is not always specific and must be taken in the context of what's going on clinically. And then looking at pulmonary function tests. So all of these have limitations. So where do we go? What tool can we use to refine our diagnosis of AMR? And she basically was looking toward what's coming out. And we have eplet matching, the intragraft DSA, which I mentioned briefly, and then non-HLA antibody identification, as well as some of these tissue-based molecular techniques, the molecular microscope, nanostring, and cell-free DNA. And her point to us was maybe with some of these newer techniques, we can objectively and confidently assess the risk of each patient with a DSA, treating those that would benefit and holding them on therapy for those who would not. And lastly, we had a really very, very nice talk by Chris Enzor, who is a PharmD out of Florida, and he reminded us that in no place is there CD20 on a mature plasma cell. And this is important because it is not helpful in the treatment of, or evidence shows that it is marginally effective in using it to treat AMR. he highlighted that one of the newer medications available is an anti-CD38 drug, which is being used in multiple myeloma. And while this is very exciting, CD38, as you know, is not specific to the plasma cell, that it is also present on regulatory T cells and regulatory B cells, which is a little bit scary. And finally, his thought to us was that AMR is both an acute and chronic problem that irreparably modifies the state of immunoquiescence, requiring immunomodulation to extend quantity and quality of life. And I thought this was a really nice summary and a very dramatic way to put it, showing that we really do need to spend more time investigating AMR in the lung. And so I'm going to skip forward to our last slide. So where are we here with the lung, and what do we need to move forward? And then Adam had proposed a molecular project for the lung, looking at AMR and assessing transbronchial biopsies using the NanoString technology. And I'm just going to go ahead and click through for all of these. And this is where we would like to focus our efforts for the next 2 years. So hopefully at the next meeting we can have something to share with the group. Thank you. Be happy to take any questions.
Thank you. So the next speaker is Patrick Brunval from Paris, covering the summary of the heart